I am a physical therapist. I am an innovator. I am a teacher. I am a published author. I have been teaching for the better part of a decade, or probably a decade now. I feel like we're on this earth for a very short time, relatively speaking, and try to make the biggest impact that you can. I find if you do not warn these people that they're going to be more sore, they think you're hurting them, okay? I have been doing this 20 years, okay? I have been treating patients for 20 years. And what I have found about psychology of patients is you need to warn them because otherwise they think you don't know what you're doing and you're hurting them. Yo, everybody, what's up? Physical therapist, Dr. Ryan Whelton, coming to you from just outside the Tampa Bay area. If you are new to following me, I am a physical therapist. I am an innovator. I am a teacher. I am a published author. I have been teaching for the better part of a decade, or probably a decade now. And I have a clinic where most people have failed everything type story that comes in here, you know. And I've learned to get exceptional results over the years with this patient population. I created protocols, I created courses that I teach, that I do in here, and I created protocols for people to do of what I do in here. So I just found out that my papers, so if you're new to follow me, I publish papers, I've published protocols, I've published papers in medical journals. Some of the things that some of the things I've come across in my career, some of the innovations, I've published diagnostic procedures, protocols on how to get, X condition better, Y condition better that I do in here. I just found out that I asked the Journal of Practical Pain Management, where I've been publishing, I said, how is my papers doing? And so the last time I published root cause of SI joint dysfunction in 2020. I published root cause of plantar fasciitis, I think, right after that. 2022, root cause of sacral torsion shear in 2022. And I think in 2023, I published shoulder differential diagnosis with a bunch of protocols in there. Anyways, they got back to me and they showed me a graphic that I pinned to my social media. If you don't follow me on social media, it's Whelton Methods. And it said that my sacral paper, I believe, was like 13,400 in the last 12 months. Now, I published that in 2022. And then in my my SI paper was like 11,500 or something like that. You can check the exact number. And then my other ones are 5,000, 3,000. When I got that, I know nothing about this stuff. I just publish papers. I don't really get into academic research or anything like that. This is how you have to do it in medicine. So this is how I do it, right? And anyways, I thought that was low. I thought those things should be getting 50 to 100,000 reads a year type thing. Anyways, so I just was curious and I looked it up. I plugged it into AI and they said that those views are historic, that they are considered viral and they are considered evergreen, meaning a foundational paper that people read for orthopedics to understand conditions. So that was really cool to see that people are reading these papers and sharing them with people. It makes me happy. That's why I did it, is because I wanted to help people. I feel like we're on this earth for a very short time, relatively speaking, and try to make the biggest impact that you can. So if you're like me and you learn to get exceptional results when patients have failed everything and you do the same protocols with people, then, why not share it type thing. So I did. And apparently it's making medical history. So that's really cool. You should read my papers. I also published the root cause papers called Root Cause of Carpal Tunnel Syndrome. I also included in there trigger finger dequervins, medial and lateral epicondylitis in there. And that was rather recent that I published that. So you have not read that paper. Anyways, so when it comes to that paper, the paper Root Cause of Carpal Tunnel Syndrome, I have a very different take on it, and I don't generally have issues getting carpal tunnel better, probably for the last 15 years. Anyways, that's what I do. So you can go to my website, wheltonmethods.com, Whelton methods.com, and you can go to publications and read my papers. I put them all right there for people to reference. So if you ever need to read my papers, then please go there. I also have my online courses. I have my rehab results course, which is all of my orthopedic protocols with the exact sets, reps, exercises that I do in here. Then I have my myofascial courses. So my myofascial courses are really cool. So years ago, like 2016 or 2017, I published a paper in the Journal of Comprehensive Integrative Medicine detailing in this paper that in these cases, these points that I mapped in the body at certain joint angles and angles of pressure served as off switches, essentially reflex pain off switches points in the human body. So the results I mapped out in there are pretty dramatic. And anyways, I created courses of about 1,000 pages of maps of the body. And like in my intro shoulder course that I have on my website that you can download, I show you how a different part of the body connects to the shoulder and how you can relieve pain immediately. But if you can't do that, then we'll give you your money back. And the majority of people that you attempt the method on. I've had that offer, I think, for probably since the course came out, and it's wildly successful. So give it a shot. You have literally nothing to lose. So I got that. And then a similar course to that is my sciatica cervical radiculopathy course. And then I have my cash-based business model that I teach people how to open and run clinics. Now, listen, I started a membership group. For years, people asked me to teach live. People have emailed me, they've messaged me over the years. What do I do with my patient that has this? What do I do? What do I do? What do I do? And I decided to create an awesome membership group, a group of amazing clinicians, forward-thinking clinicians like us that want to get better results, don't want to stay in the box anymore, and want to get better results. And I teach in there on School, SOL, of a community of people where I go live. I teach live Q&A. You can even bring your patient in and we can all learn. And I help diagnose, treat, and show you, guide you as to what I would do with a patient with that. So really, really cool. My goal is to get us up here diagnostically, like not a problem when patients come in. I want people feeling that way. When patients come in, it's just like, no, I know what's wrong, or I know how to evaluate this patient. And it's not something you're intimidated by. A lot of people feel like they have imposter syndrome. I know that. People have told me that. And I feel the best way to overcome that is to, number one, get results. So read my papers or take my courses, but also, to have a mentor or a coach, and that's what I am in those groups. So if you join my membership, you get massive discounts on courses, and then I'm gonna be your mentor, your coach, live with live Q&A, so you can ask me questions. And it's a really cool community that I've created. So I'm really excited about getting that to continue to grow and help people, because that's the goal. So anyways, go to wheltonmethods.com, Whelton methods.com to sign up for my membership. Get massive discounts on courses. I think up over 50%, depending on what tier. And then also you get the live Q&A, teaching, coaching. So really, really cool. Plus new innovative techniques and methods that I share only in that group. So that's that. Okay, so today we are talking about differential diagnosis of thoracic pain, posterior thoracic pain. So recently I have had a bunch of people come in with this pain here. And they come in and they say, I got this gnawing pain or sharp pain sometimes. It's been killing me for years. They don't really know what to do about it type thing. And Interestingly, I've actually had it. So I've diagnosed these people with rhomboid spasms, okay? Which years ago, probably, I don't know, 10, 12 years ago, I was in my clinic and one day I was like, oh my God, like, what is that pain? And immediately I knew what it was, but I was shocked at how bad it hurt. It was like a sharp, gnawing pain, like right up in there. And anyways, I rehabbed it and I got it to go away, but I was shocked at how bad it hurt. So I don't blame these people for, showing up in a physical therapy clinic and looking for help, because that hurts. So one of the things that I talk about more in depth in my community, my membership group that you can register for on my website is it's diagnostic. So when I diagnose, first of all, you should rule out what you can rule out. And oftentimes I find you can get to the answer of what's wrong with the patient if you just rule out like a bunch of different things. There's only like one or two things left. That's how I do it. Okay. And I'm pretty accurate diagnostically. So, okay. So we're talking about in this region up here. So the question would be is what could that be, right? Well, if the person describes it as a gnawing pain, I'm thinking rhomboid spasm. Usually that comes to the top of my head. But my last patient that I had yesterday with it, that I evaluated, described it as a sharp pain. So sharp pain I find can be, mechanical pain, rubbing, like SI joint patients will describe a knife going into their back. That is sharp pain in their back. It doesn't have to be that way. It could be an ache, it could be tightness, it could be all kinds of things. But they will describe it as a sharp knife-like pain in their back sometimes. That is mechanical pain. So the differential diagnosis of that region of your back is either a rhomboid spasm or a rib misalignment. Okay? And it's easier to diagnose than I believe you think it is. So what I do is this. Hold on, let me get it. Annette, can you come here for a second? All right, so everybody know Annette, been away to physical therapy. Face that way, there you go, like that. So these people come in and they say it hurts in here. In fact, when they just say it hurts in my mid-back, I usually walk up and I start palpating right along the medial border of the scapula so if you take her, let's see here, and put that there, they complain of pain right in here. But the interesting thing is they usually have a knot, I find, when you have a rhomboid spasm. And so if you push, like I did with these last 2-3 patients, if you push right in there, you'll usually find a big knot, okay? And then the other thing that it could be if it hurts, let me go back to rhomboid spasm. With a rhomboid spasm, I find that like you can't aggravate it by moving it, okay? It hurts to touch, but they're like, oh yeah, that hurts. But like I'll have them raise their arm up and, like activate the rhomboid and they're like, yeah, no, it doesn't hurt anymore. Like doesn't increase the pain, but it hurt to touch there, which is a tip off that it's orthopedic. And then also I use my myofascial method to get them out of pain immediately. And that works on musculoskeletal pain. So in these 2 patients, I use my myofascial method, different parts of the body, boom, their pain was gone in their back. I've confirmed what the problem was. The pain's gone and they have a big knot right there. And so I just confirmed what the actual issue was. Now, the other thing it could be is rib head misalignment, sometimes facets, but I find rib head misalignments are more common. And I see them and they're in massive pain. I've talked about this before. Rib head misalignments, a lot of these people are totally debilitated. Like I had one lady that couldn't stand up more than 20 minutes for 12 years with a sharp pain in her mid-back here that nobody could figure out. Sometimes it radiates around. It's terrible. Lay on your belly for me, Annette, please. So the way to tell that would just to do, put your arms out to the side. And what I do is they taught us in school to like stabilize the spinous process and then spring one. I don't do that. And the reason why is because you can actually feel the spinous process move with you when you spring the rib. So like, are you really doing what you're intending to do, which is to spring the rib and disassociate it from a costovertebral misalignment? Are you really doing that if the whole spinous process is coming with you, right? So what I do instead is I spring both ribs at the same time. Because if you think about it, if you do that, spring both ribs at the same time, they're going like this, and the spinous process stays in the middle, and you're getting the job done. So I take the same rib, so like let's say, T6, I take T6 with both hands, and I just spring like that. And then I go up and up and up. And oftentimes you'll hear the popping, right? And then I'll have them stand up. I will have them stand up, and I'll say, do you still have that pain there, twisting or whatever the motion was? If that made it go away, then you know it was a rib head misalignment, right? Because that's what you did. And then sometimes it's the actual facet joints. So you just mobilize that. But I find that to a much lesser degree. I know people go and they get adjustments all the time, and it helps. But I urge my chiropractic followers just to move over to the ribs, because I find these people are screwed. That come in here, they're just like, it's crazy what I see. Like they've usually like failed everything, and they tell me like, I've had MRIs, there's nothing there. It wraps around, because what's happening is their rib head costovertebral misalignment is radiating through their ribs and coming around, causing costochondral pain. So it's really something that I urge everybody to do. But you can rule out a costovertebral misalignment just by doing rib springing like that, or facet mobilizations. But go ahead and stand up for me. So let me say one last thing about costovertebral misalignment. So let's say you do the rib springing and it doesn't work, right? And the person says, no, it still hurts, right? Well, I'm not done until I do this to them. I grab them right here and I push medial and then have them do the aggravating motion, okay? Medial compression of the anterior ribs. So what I'm doing is performing a gapping motion, a gapping at the costovertebral junction on both sides. And then I have them try to go find their pain. And if you can get the pain to go away, thanks, Annette. If you get the pain to go away, then you just confirmed that was that, okay? So now you know your diagnosis is either rhomboid spasm, okay? You got, I find to a much lesser degree facet dysfunction than rib head misalignments. Maybe it's because people come to me that have failed everything, type clinic. I don't know, but these people that have failed everything with this thoracic pain, I mean, you should see what these people go through. And if nothing shows up on the MRI, sometimes they get referred to psych, and a quick ribs. And I ask them, I'm like, have you been to a chiropractor? Because a lot of times they do that all the time, like with every visit type thing. And they say, yeah. And I said, did you get relief? No. And what I think is happening is that people are realigning their facets, but not moving over to the actual rib head and doing rib springing. That's what I think is happening, because like, why else wouldn't you get relief? Because that's what I do in here, is just mobilize the rib, and the person's pain goes away. So, but in these two or three cases that I've had recently, usually see them in threes, they have had this gnawing pain on the medial border of their scapula, and they're tender to touch, and you can feel this big knot. So they have a muscle imbalance. So you just have to fix their muscle imbalance. And I go over much more in depth in my rehab results course of exactly what to do, or what I do to fix these people. I'm not worried about these people. The thing about patients doing the rehab is what I tell all of my patients with a rhomboid spasm that I'm doing the rehab with. I tell all my patients, I say, I literally tell them this. I say, I walk around this clinic all day long and tell people, do not put yourself in pain. Do not put yourself in pain. Do not put yourself in pain. If you're putting yourself in pain, these rehabs take longer, with the exception of frozen shoulder, post-surgical. I said, this rhomboid muscle is angry because it is weak. And I said, we have to strengthen it. So and we have to fix your posture. So unfortunately, I said, you can be more sore for about 3 weeks. I find if you do not warn these people that they're going to be more sore. They think you're hurting them, okay? I have been doing this 20 years, okay? I have been treating patients for 20 years. And what I have found about psychology of patients is you need to warn them, because otherwise they think you don't know what you're doing and you're hurting them. So if, like a frozen shoulder patient, if it's gonna hurt, you've got to tell them it's gonna hurt. You know, you can't just start hurting them. You know, like you have to warn them what to expect with these rehabs that you're doing with them. And I this week I warned 2 people that you're going to be more sore for about 3 weeks as we strengthen this, but it usually goes away in about 5 weeks with my patients. So that's very important. Okay, but other than that, that's that, and that's how I do a differential diagnosis in the thoracic. Those are basically the three main things that go on there. You can have arthritis, herniated disc. I go over that in my rehab results course, how I rehab those. But other than that, I'm not too worried about thoracic pain. You just have to get the right diagnosis. So if you want to get better at diagnostics, join my community, wheltonmethods.com, WHELTON methods.com, and join my community where I teach live Q&A and I coach and mentor. Okay? Other than that, peace. Love you all.